So when we talk about grade, and particularly when we talk about grade and guidelines, we often talk about three major outputs of a grade process. We have a grade evidence profile, or what's sometimes known as a grade summary of findings table, which is essentially an abbreviated grade evidence profile. And this is what you would all do as systematic review authors, or I hope you all do as systematic review authors, to present your certainty in the synthesized evidence. And within these summary of findings tables, we show or explain why we may have downgraded the evidence or downgraded our certainty in the evidence, transparently report the reasons why we did do this, and also present the results from our systematic review in a way that's more easy to interpret. When we move to the decision-making perspective with grade, we develop these grade evidence to decision tables, and these outline all of the key criteria that should be considered when actually making a decision or a recommendation. And it shows the evidence for each of these key criteria, and then the judgments of the panel who are making the decision or the recommendation. And then, of course, the final output is this recommendation, which should be assigned a level of certainty, a strength of recommendation, and should be an actionable statement that can be taken up in practice. So how do we establish our certainty in the evidence? Traditionally, we would start off at different places, whether we had a body of evidence from randomized studies or a body of evidence from non-randomized studies. If we had randomized studies, we would start off with high certainty in the evidence. With non-randomized studies, we would start off as low. And then we would consider the 5 domains to downgrade our certainty in the evidence. Of course, risk of bias, which we've heard a lot about today, inconsistency as well. So if the results of the studies are not aligning with one another, indirectness, so whether or not the results of the studies are actually applicable or provide direct evidence to the populations or jurisdictions that we want to make recommendations for. Imprecision, which is largely related to the width of the confidence intervals, particularly around important decision-making thresholds. And then publication bias or dissemination bias, which is where we might suspect that we don't actually have all of the evidence that exists on a topic, and that there may be some studies that we have missed. And then for non-randomized studies, there are also these domains which can upgrade the certainty of evidence. We have a dose response criteria. So the more that you are exposed to the intervention, you see a corresponding increase or decrease in the actual outcome, more you're exposed to the exposure or variable, you see a corresponding increase or decrease in the outcome. A large, consistent, and precise effect as well is one of the criteria for increasing our certainty in the evidence, and opposing residual confounding. So these might be confounders which were not included in your analysis, but may be working against an effect. But regardless of that, you may still see an effect, and that may increase your certainty in the evidence. And then you end up with your certainty rating of high, moderate, low, or very low. So just a quick recap there on the grade certainty domains. Now, when Robin's Eye was released, as Julian's already talked about earlier, we realized that the previous guidance about only ever having not serious, or very serious concerns, which correspond to not downgrading at all, to downgrading 1 level, to downgrading 2 levels, was not going to be as helpful anymore. The reason, or we needed something different, because with Robin's Eye, because it compares non-randomized studies to this target trial, which hypothetical target trial, which Julian introduced earlier, we are starting off kind of with a different baseline in terms of our risk of bias assessment. So we should actually start off as high when we're assessing studies with Robin's Eye, and the same goes with Robin's E, etc. But then we still, if needed, we still need to downgrade perhaps an extra level for risk of bias if there are extremely serious concerns about risk of bias, so that we weren't going to get different certainty ratings depending on whether the different risk of bias tool that we use. So that's why we required this additional level. And then one of the innovations in grade, I guess the first innovation, is that now that we have this extremely serious, we can actually go to extremely serious and sort of downgrade 3 levels. We've actually started to realize we can apply this to some of our other domains as well. particularly when we're using thresholds for decision making, which I'll get into a little bit later. So in the past, we used to only have serious or very serious concerns per domain, but now we see that we can actually use serious, very serious, or extremely serious across a number of domains. Okay, so that's the sort of establishing our certainty in the evidence or synthesized results from systematic reviews. But of course, in guidelines as well, grade have a lot of guidance and have developed a lot of materials to help panels and groups move from our synthesized evidence to actually making a recommendation or a decision. Through lots and lots of work, these are the criteria that were decided upon as being the most important criteria to consider when moving from the evidence to a recommendation. And of course, these criteria may change based on the perspective you're taking in terms of what sort of recommendation you're making, whether it's for sort of an individual patient at an individual clinician level, through to if you're taking a health systems perspective or a coverage perspective. But these are largely the criteria we consider. Benefits and harms, of course, but also values and how people value different health states, resources required, cost effectiveness, equity, acceptability, and feasibility. And ideally, what we would have is we would have synthesized research evidence for all of these criteria. And so we'd be able to actually do systematic reviews of the research which inform the values criteria and the cost effectiveness criteria, the equity criteria, etc. And some of the advances in grade are actually in line with developing methods to do systematic reviews of these different criteria, and then developing grade guidance for how we establish the certainty per criteria as well, not just the certainty in the benefits and harms, which previously there has been a lot of focus on. And then, of course, the panel make their judgment based on this. Okay, so that is a very brief recap of grade. And now what we're going to do is jump into some of the advances with grade. So grade is a working group of over 600 people. 600 people, like many other people in Australia, people are interested in using evidence to inform decision making. And it's not a static methodology or framework. It's continuously updated. We're always identifying new challenges and trying to improve the guidance. The best place to go for guidance about using grade is the grade book. Now, previously there was a grade handbook, which some of you may have seen, but since the handbook was first published sort of around 2009, 2010, there have been a lot of advances in grade, a lot of new methods, new guidance and things, and some of the old papers are now out of date. So the best place to go for a really simple overview of current approved grade guidance is a grade book. So if you haven't seen this resource before, I would recommend you bookmark it and head here. This is, and a lot of the material I'll be discussing today is reflected in this grade book. Okay, so as I mentioned, grade are developing approaches to establish certainty in lots of different types of reviews, not just reviews on the effects of interventions or reviews that can inform benefits and harms or desirable and undesirable consequences criteria. The work I'm going to discuss the most today is related to this quite recent guidance, Grade Guidance 42, which is all about using thresholds for judgments on health benefits and harms. It's not the most recent paper. It was Grade Guidance 42, but I just saw earlier this week that Grade Guidance 44 has been accepted, which is about incorporating or addressing non-randomized studies of interventions along with randomized studies, which I think many people here might be very interested in. That just came out, just published in JClin Epi. Okay, so let's start off with the question: what are we actually establishing our certainty in? When we talk about using grade, we apply the grade approach to establish our certainty in a body of evidence. But what are we actually establishing our certainty in? And once upon a time, we were focused on establishing our certainty or our confidence in that the estimates of the effect are correct. So we're really focusing largely on our certainty in the point estimate. And that's what we would do in systematic reviews. But over a fair bit of work and a lot of discussions, we realised that actually we're not necessarily establishing our certainty in a single point estimate. Rather, we're actually rating how certain we are that a true effect lies within a particular range or one side of a threshold. And this is much more useful if you're going to use those results to inform a decision. So an updated definition for certainty is reflected here on this slide. The certainty of evidence reflects our confidence that the results are in a particular range or above or below a certain threshold. So you can see this concept of thresholds is really coming through. And if we have high certainty, then we can use this sort of standardized wording. The intervention reduces or increases the outcome. When we get to moderate, the intervention probably reduces or increases the outcome. When we get to low, the intervention may reduce or increase the outcome. And when we get to very low certainty, the intervention may reduce or increase the outcome, but the evidence is very uncertain. Okay, so let's spend some time talking about this concept of thresholds. And this is really critical, I think, now to the new or modern grade guidance. We struggled for a lot of time using terms like minimally contextualized, partially contextualized, fully contextualized in terms of how we were making our decisions or our interpretations. You can forget all of that because that was way too confusing. No one really understood what we were talking about when we were talking about minimally versus partially versus fully contextualized decisions. And the approach that we are now using are setting these thresholds for decision making. Okay, and these are, once again, these are the papers where this is discussed here. Okay, so when we talk about thresholds, well, there's probably three different options that we could use if we're going to set a threshold to inform our certainty ratings. We might set a threshold as the null, which we used to call the minimally contextualized approach. So you might say that if we have a risk ratio or relative risk, we might simply set our threshold as a relative risk of 1, which obviously means no difference between groups or the null. We could also set our threshold as a minimally important difference. So the minimally important difference is the smallest result that would be worth acting upon in a clinical setting. Or we could actually set thresholds for small, moderate, and large effects, whether they be beneficial or whether they be harmful. And when we start talking about decision-making and guideline development, actually setting thresholds for small, moderate, and large effects is really, really helpful because we're often faced with this challenge where we need to do this trade-off between benefits and harms. So actually having thresholds for what might be a small benefit versus a moderate harm, etc., can really help inform the panel's decisions in these discussions. Now, maybe not everyone will agree, but if we think about setting the threshold as the null, it's not really that helpful for end users. It's because, and we all know this, because you might have a really, really small statistically significant effect, which might not be clinically meaningful, for example. So there's a couple that helpful as the threshold. Maybe in some scenarios, like early phases of drug discovery, it may actually be helpful. But from a decision-making point of view and then implications for sort of practice point of view, it's not particularly helpful. What about the minimal important difference? So this could be quite helpful, especially if you're not doing a systematic review in the context of a guideline. How do we find out what the MID is? There's a few different ways you can do this, of course. There may be empirical evidence which has and standard MIDs that are used in that field. For example, if we think about a numerical rating scale of 0 to 10 for pain, it's been established at a 2-point change. So a mean difference of 2 would be considered the MID. And of course, if you're doing this in the context of a review and you've done public and patient engagement, then you could actually work together to stipulate a priori what your your MID threshold might be here. So what would this actually look like? So this would be an example where we have set an MID for benefit and then for harm. And in terms of rating the certainty of evidence from a grade perspective, if we imagine that each of these estimates are the results of a systematic review or a meta-analysis, you can see here that when we have our first estimate, you can actually see that it's crossing both this benefit threshold and this harm threshold. And this can be reflected in your judgments regarding imprecision, right? Because you can see that the confidence intervals are crossing both these thresholds. Here we have our estimate, it's crossing one threshold, and once again, that can be reflected in our judgments for imprecision. Here we have our third estimate, it's all within benefit, so we can probably don't have any concerns from an imprecision point of view, because the confidence intervals are fully encompassed within that threshold. And then here we have confidence intervals which cross the null, they cross that line of no effect, so it wouldn't be a statistically significant finding, but it's all within this trivial or no effect range. So we can be pretty certain, or we don't have any concerns about imprecision, because it's not necessarily going into sort of appreciable benefit or appreciable harm. So we're really trying to start advocating for even systematic review authors to start doing this and setting these thresholds. And in actual fact, now that we are using thresholds, it's actually really hard for me to try to go back where you haven't set thresholds a priori. Because when you're doing your judgments about imprecision, you're making all of these sort of implicit or value judgments about how precise or not the effect is. But you're just sort of, you have your own internal thresholds that you've been applying. So it's much better to stipulate these thresholds a priori and be very clear about it. Okay, the other thing that we can do is then set small, moderate, and large effects. And when we think about sort of a dichotomous outcome, we might actually set these in a way which corresponds to how many times we might see that event per 1,000, which corresponds to how we present the information in a grade evidence profile. So you might actually say that you'd say that if we see 40 more events per 1,000, that might correspond with a small effect, and then go on from there. How do we define, or how do we come up with these thresholds? Well, there's a few different ways that you can do it, but the important thing to consider is that these aren't just going to be standard thresholds for all different outcomes, because outcomes are different based on their severity and the way and their importance to the actual person. So there won't just be a standard threshold for every single outcome, and different groups might make different decisions about what is a small, moderate, or large effect in their context for those outcomes. And of course, for life-threatening outcomes, even a small increase or decrease could be considered important. Okay. However, if you're struggling to set those thresholds, there has been some empirical work. So there was this very large survey of clinicians, patients, the public, researchers, methodologists, etc., which tried to develop these standard coefficients that you could use to then inform your thresholds based on the utility of the health outcome. So when you have, most of you will probably be familiar with health utilities, where you have when you have a utility of 0 when you're dead, and perfect health is a utility of 1. Using these utilities against these standard coefficients, you can then develop your thresholds in terms of a number of events per 1,000. Essentially, what they correspond to when you have a disutility of 1, so 1 minus the utility, is that you would be looking at 13 events per 1,000 for the small threshold, 32 events per 1,000 for the moderate threshold, and 62 events per 1,000 for the large threshold. Now, people once again, so that's obviously looking at how many deaths per 1,000 you would consider extra deaths or reduced deaths, you would consider as a small, moderate, or large effect. Now, when I did this, I did this survey, I actually had a lower number than that. I think I said 9 or 10. But going across the whole panel and everyone who did do the survey, it came out as 13 events. So imagine then that you had a utility of 0.5. The disutility then would also be 0.5. So what you could do is then you would, obviously we have our synthesized estimate here from our meta-analysis. It was an odds ratio of 0.66. This corresponded to 30 fewer per 1,000 events for that particular outcome. Now, using these empirically derived coefficients, we could actually work this out to see what our score would be using this method. And because when we do this, we have our effect is 0.015, it's greater than threshold of 0.135, then we can say that it's a small effect. Now that's a little bit more complex than actually just using this and setting thresholds a priori. So what we would do here is we would times our utility, disutility, by that coefficient would come up with a small effect or threshold of 27, moderate 64, and large of 125. So when we saw an effect of 30 fewer per 1,000, we could say that this is small. Okay, all right. And then what can we do for continuous outcomes? Well, if there are empirically derived MIDs, we could use this because the MID should correspond to a small effect. Or we could use, the standard effect size interpretation of 0.2, 0.5, 0.8, for example. But also you discuss it with your panel and your context. Okay, so that is some of the guidance about thresholds. And the thresholds are now not only helping us discuss issues like imprecision, but they're actually really useful for the other grade domains like inconsistency, risk of bias, etc. as well. So here's an example where we have, in both results, we have an I-squared of 99% and statistically significant heterogeneity or differences between the results. But you can see in this first example that actually, even though there is high inconsistency according to I-squared, all of the point estimates and most of the confidence intervals are lying within that one threshold. So we may not actually be concerned about inconsistency here. Whereas when we have the same sort of scenario, but you can see we're actually on different sides of our threshold here, we may actually then have concerns about inconsistency. Okay, now I wanted to quickly run through an example of what we've been doing in the Australian Motor Neuron Disease Guideline, where we've actually created health outcome descriptors. We've then sent these around to a panel and advisory groups, asked them to rate the importance of these different outcomes, and also to rate their utility of these outcomes as well. So they rate their importance, so we know that we should focus on the critical outcomes when we make recommendations. And then based on the utility ratings as well, which the panel and advisory groups gave us, we were then able to use this approach that I've mentioned to actually then develop these thresholds for our different outcomes. And then, so here's an example of, it's called Riluzole. It's a drug which hopefully reduces mortality and increases length of survival in people with MND. And you can see here that the final result was 123 fewer per 1,000. And when we map that onto our decision thresholds, we can see here we've got our decision thresholds of 13 per 1,000, 32 per 1,000, 64 per 1,000. Where would that actual estimate lie? It would actually lie in a large range, but you can see that because it is ranging from 177 fewer to 54 fewer, it is crossing over into our moderate range. So we actually, in this case, we would downgrade one level for imprecision because it's crossing one threshold. So we ended up with moderate certainty evidence for a large effect for Riluzole for reducing mortality. You could also look at this in a different way, though. If you're only interested in establishing a moderate effect, so if I changed my context and I wanted to establish my certainty in a moderate effect here, because maybe there aren't as many harms that I need to do in this trade-off, then I would actually possibly have high certainty evidence for at least a moderate effect, because the confidence intervals aren't crossing into a small range. But in this case, I'll need to check something called the review information size, or the optimal information size, to see if this is sort of a valid conclusion. So what's the implications? So the implications are that I think we should all be moving to this thresholds approach when establishing our certainty in the evidence. Even if you're doing just a systematic review and you're not doing it as part of a guideline, I think there's still a lot of benefit. And I think it actually really helps you in the end as well, if you set at least thresholds for an MID perhaps, or just 2 thresholds for benefit and harm. And of course, if you ever have any questions about grade, you can get in touch with your local grade centre. We've got one here in Adelaide, and of course there's one in Melbourne as well. But thank you.